Alright guys, let's get started. This is Mrs. S. This particular Explain Everything will focus on meds that we would use for hypertension, for atherosclerosis, and for angina. How many of you guys are feeling stressed this semester? Well, just, don't worry. You're probably halfway through your semester. Cardiac drugs are difficult, but if you study them on a day-to-day basis, you're going to be okay. So just a few terms that might be used throughout the Explain Everything that you need to make sure you have a grip on. Chronotropic, that means it affects the heart rate. Chronotropic, heart rate. So if it has a negative chronotropic effect, it will slow the heart rate, for instance. Inotropic, it means that it affects contractility. So inotropic means that it will affect contractility. So if I say that it has a negative inotropic effect, that means it will decrease contractility. Okay? Very good. Alright, let's get started on the drugs for hypertension. Are you like Ruger? Are you confused about the drugs that we use for hypertension? Listen, pretty simple. We're going to go over the A, B, C, and D's of the antihypertensive drugs. So, the drugs used for hypertension, you can remember by going through the alphabet, A, B, C, and D. Let's get started. Okay, the first A, your alpha adrenergic blockers. Remember guys, these guys end in syn, so that's what you're going to look for on your test. They block the alpha adrenergic receptor sites, and therefore they result in vasodilation. So, you're looking at this guy and you're thinking vasodilation. Why does he have stars around his head? It's because when he gets up, he could experience orthostatic hypotension because of the vasodilation. Alpha blockers obviously are used for hypertension, but they can also be used for BPH. Now remember, some of the side effects, obviously hypotension, orthostatic hypotension. You could be like this guy and feel faint or dizzy, lightheaded. They can cause an increase in the heart rate. It's a rebound tachycardia. And they can cause some nasal congestion, edema, and weight gain. So what do you guys need to do? Obviously take their vital signs. Compare them to their norms. Tell your patients, take these at bedtime. And tell your patients to watch for first dose syncope. That they need to change positions slowly. And they need to monitor their weight. Okay, our next day, angiotensin-converting enzyme inhibitors, your ACEs. Your ACEs, remember, they end in pril. They stop the conversion of angiotensin 1 to angiotensin 2. They don't allow it to happen, okay? And they also decrease aldosterone production, and that leads to decreasing sodium retention. So, what are some things that these guys do? We need to make sure that we monitor for a cough. A lot of times these guys just have a non-productive dry cough. It's kind of irritating. It'll cause patients to not take them. So make sure that you tell them to let you know. You need to watch for, obviously, hypotension. Okay. Now, a couple of other really important things with ACE inhibitors. They can cause a high potassium. They can result in something called angioedema, so they would need to monitor for angioedema. They need to also not be given if someone is pregnant in their second or third trimester, and they can cause neutropenia. So what do you want to monitor for? Are they effective? Is the blood pressure working? What's the renal function? What's your potassium level? What's your white blood cell count? And make sure that you're telling and talking to your patients about the potential for a cough. Your angiotensin receptor blockers, if you go back to the picture on the slide previous, it shows that they actually stop the angiotensin 2 from hitting their receptor sites, thus resulting in vasodilation. And that's why they're useful in treating hypertension. And so they're very similar to ACEs, okay? So they can be used alone or combo with other drugs. Some of your common side effects, headache, dizziness, fatigue, they too can cause the cough. Again, we cannot give in pregnancy, okay? And so they're very similar. Listen, in the previous slide I mentioned something about angioedema, and I realized I didn't really address what it is. It's rapid edema or swelling, okay, and it happens in the skin, and it can lead to a severe allergic reaction, and it could potentially lead to airway compromise. And so you just want to make sure that patients are on the lookout for this. Angioedema, a lot of times how you could describe it to a patient is that they would develop giant hives, and that they would have a lot of itching, and that they could need medical treatment. Okay, on to the B's, your beta blockers. Listen, your beta blockers end in LOL. So that's what you're going to look for on your test. These guys block the adrenergic receptors of the sympathetic nervous system. So they're blocking the beta 1, beta 2, alphas. And when you do that, when you block, you get the opposite effect. So what does that result in? It results in a decreased heart rate. Remember, that would be chronotropic, a negative chronotrope. They decrease the blood pressure, and they decrease contractility. So these guys are negative inotropic drugs. Beta blockers can be called non-selective, selective, and dual-acting. We're not going to be specifically learning about the difference or have you identify a beta blocker by whether it's selective or non-selective, but let's just talk a little bit about it. So remember, when we target the beta 2 receptor sites and they're stimulated, then what you have is bronchial dilation. So if you blocked that action, such as beta blockers do, you can get bronchial constriction. This could be dangerous for like your COPDers and your asthma patients, right? So if a beta blocker is considered non-selective, it targets both beta 1 and beta 2. But if a beta blocker is considered selective, then it's just going to target beta 1 receptor sites. And by targeting beta 1 receptor sites, you don't get that potential issue with bronchial constriction. Okay? So, what do we need to look for when we are administering beta blockers? Well, one, you got to obviously watch the blood pressure, but listen, it's a negative chronotrope, so you got to watch the heart rate too. You also have to be concerned if you're given a non-selective to someone who has COPD or asthma, and you'd want to make sure that they are not experiencing signs or symptoms of bronchial constriction. So listen, you need to monitor the heart rate, the blood pressure, your EKG. Is your patient weak, dizzy, having bronchospasms? And you should know that it can possibly mask the signs of hypoglycemia, so you would want to make sure that you're aware of that if giving these to a patient who has diabetes. And last, it's a negative inotropic drug, so it decreases contractility, so they have to be used cautiously in patients that have heart failure. Okay, so we're moving on to the C's already, your calcium channel blockers. We're just going to focus on the pines, the ones that end in pine. There are some others, for instance, ditalazam, cardiazem that don't end in pine, but we're going to focus on the pines, okay? So these guys actually stop the influx of calcium through the L channels. What does this do? It results in smooth muscle relaxation. And so these guys do provide smooth muscle relaxation. And so what do? They, as you can see here, that they actually dilate your arteries. And so here is an artery that wouldn't be considered dilated, and then here is an artery that is considered dilated. And so this is how your calcium channel blockers are going to work. Okay. Once again, these guys, calcium channel blockers, are negative inotropic drugs and negative chronotropic drugs. And so you have to be cautious. You have to make sure that you just don't monitor your blood pressure, but you're also monitoring your heart rate. And once again, anybody that's taking these could have, some dizziness, some lightheadedness. You would want to make sure that you monitor for that. Listen, they relax all smooth muscles, okay? All smooth muscles. So they kind of slow everything down. And people who are taking calcium channel blockers can actually experience constipation. So you want to make sure that they have a good amount of fluid intake, and that you warn them that this is a potential complication, and that they just need to make sure that they get plenty of fluids and fiber. The other thing, because of the smooth muscle relaxation, you can actually have some weight gain. So we want to make sure that they understand that they should never gain more than a couple of pounds in a day or 5 pounds in a week. So this is someone, again, that should make sure that they are weighing themselves, changing position slowly. And the other thing with calcium channel blockers, you're not supposed to drink grapefruit juice with calcium channel blockers. So don't drink grapefruit juice. Good news, we're already on the diuretics. We've already been through A, B, C, and D. And you guys know the diuretics. We've not talked a lot about preload and afterload, but these drugs that we've been talking about, they work on preload and afterload. And so if you're unfamiliar or don't remember about preload and afterload, make sure you go back and listen to the hypertension explain everything. But you know diuretics, you know that they increase urinary output, therefore they're going to decrease volume, right? Decrease volume, they're going to decrease your preload. We've learned that they work either in the loop of Henle or the distal tubule. And we've realized that you have got to know whether they spare potassium or they don't spare potassium, and you need to know examples of both, which is on the next slide. So we know we want to monitor the blood pressure, urinary output. You've got to monitor weights like we've talked about. Make sure you monitor the electrolytes. You pay close attention to the potassium level. So you're looking at this slide and you realize this slide is just a review. You know your loops. You know your loops can actually have the potential to decrease your potassium, just like your thiazide diuretics can decrease your potassium. Your thiazide diuretic is the hydrochlorothiazide, right? A good example of a loop is your furosemide. And then we have our potassium sparing diuretics, and that's your spironolactone. And you know that that actually spares potassium, and so you need to watch your potassium level, and potentially it could go up. You guys can read through these side effects. I do want to remind you that we have to be cautious when we are giving the loop diuretics IV, that you do not want to exceed 20 mg per minute when you're giving them, because if you repeatedly push your loop diuretics faster than 20 mg per minute, it can lead to ototoxicity, and your patient could end up experiencing a chronic hearing loss. Okay, on to the drugs that we use for atherosclerosis. So the deal with atherosclerosis is we're concerned about lipid deposits in your arteries, right? And so we need to get after someone who has hyperlipidemia, and they need to typically be placed on a medication, especially if diet and exercise has failed. And you know, the statins, and that's what we're getting ready to talk about, the statins have kind of revolutionized this particular class of drugs. And so the statins are your HMG-CoA reductase inhibitors, and they are used by the liver to produce cholesterol, and they inhibit this particular enzyme. And not a lot of side effects. You do need to make sure that these patients understand that they have to have baseline lipid panels and LFTs, liver function test, but otherwise mild transient GI disturbances. Now there is a concern about the myopathy. By blocking the HMG-CoA reductase, it can lead to muscle pain, and so we have to talk to the patients about this particular muscle pain, and we have to make sure that they understand to report it if they're experiencing muscle pain, and that it could lead to a potential serious complication called rhabdomyolysis, which is a breakdown of the muscles, and that's why they need to report it. Now, if it is verified that they are not experiencing rhabdomyolysis but a side effect, the myopathy, then they can typically be put on what we call CoQ10, which is an enzyme that can be bought in the store without a prescription. And again, they need to monitor their liver enzymes, they need to monitor their lipid studies, and the majority of drugs that are used for hyperlipidemia are not safe in pregnancy. Your bile acid sequestrants definitely work a little bit different than the previous drugs that we talked about. They prevent the reabsorption of the bile acids in the small intestine. The bile acids are actually necessary for the absorption of cholesterol. And so the thing about these particular drugs is that they are okay in pregnancy. Okay, so you can use these in pregnancy, the only one. You have a couple of examples. These guys typically have a lot of GI disturbances, but they tend to disappear over time. And so just encourage the patient to take the drugs on a regular basis, and the nausea, the belching, the bloating, the heartburn tend to go away or disappear over time. Okay, niacin. Niacin like we take for vitamins, except for niacin taken for hyperlipidemia, we take it in much higher doses. Can be purchased over the counter, and it is effective in lowering your total serum cholesterol. And so a lot of times it's effective, and it is not expensive. Now it has some side effects too. Again, not safe in pregnancy. And the biggest complaints is flushing. The flushing is a result of a histamine release caused by the large doses of niacin that you have to take. The flushing can lead to itching and some GI disturbances. Again, over time, the side effects tend to subside, but they have found taking aspirin or an NSAID 30 minutes prior to taking the niacin actually helps with the flushing and the itching. Okay? And you should do so by taking the aspirin or the NSAID. You should obviously make sure they're not allergic to those particular drugs, and that they understand that they should take those particular drugs with food. Your fibric acid derivatives are a older class of hyperlipidemia drugs. For a long time they really didn't understand exactly how this particular class of drugs worked, but they are believed to work by activating the lipase, which helps to break down the cholesterol. There are a couple of examples. Again, these guys, you can't take them in pregnancy. A lot of abdominal discomfort, diarrhea, nausea, and it does tend to go away over time. So you need to make sure that patients understand this, and you need to monitor the lipid panel and the LFTs for patients that are on this particular class of drugs. When you have someone who has atherosclerosis, there is always the concern that not only do they have hyperlipidemia, but with that and the buildup of the plaques inside their arteries, that there is also need for anticoagulation to prevent further blockage. And so we're going to focus on some anticoagulants. I want you to make sure that you understand that anticoagulants help to prevent clot formations, that they have no direct effect on a clot that is already formed, but these guys are used to prevent clot formation. We're going to focus on warfarin, Lovenox, and heparin. In general, when someone is on an anticoagulant, your considerations are the fact that they're obviously at risk for bleeding. And so we want to make sure that we're aware of that, and that is passed along to the patient. The bleeding could be localized, such as gum bleeding, or it could be systemic, such as a GI bleed. And so we want to make sure that we are telling these particular patients what to watch for when they are sent home on an anticoagulant, and that it does increase their risk for bleeding. And we also need to be aware of these drugs could cause what is known as heparin-induced thrombocytopenia. Hopefully you know what thrombocytopenia is, but that is a low platelet count. Okay, first, heparin. When we give heparin, we monitor what is called the activated partial thromboplasma time, APTT. It's parenteral, so we give it sub-Q, or it can be given IV. It can be actually given IV push or bolus followed by a drip. Short half-life, which is good. We can turn it off, and within an hour or two the patient can be released from the hospital. If we happen to give too much, the reversal agent for heparin is what we call protamine sulfate. Okay, protamine sulfate. We're going to monitor the APTT. You should know that a normal APTT is 22 to 32 seconds, and we are placing someone on heparin. We typically want that APTT to be 1 to 2 times its normal in order to be considered therapeutic and having the desired effects that we would like for it to have. Okay, this is what a bag of heparin looks like that we would be giving IV. And so we have to make sure that when pharmacy sends it up, the patient's placed on a particular protocol, typically weight-based protocol, we need to make sure that we verify or check pharmacy's math. And so a lot of times it'll be that the patient is supposed to have so many units per hour. And so in this particular case, let's say the physician writes that the patient is supposed to have 800 units per hour. The patient is supposed to have 800 units per hour. So we look at our bag. Our bag tells us that we have 25,000 per 250, right? And what's our desired? Our desired is 800, and we're solving for x. So you have 250 times 800, right? Divided by your 25,000, giving us a pump setting of 8 mLs per hour. So you do need to verify, guys, the work that is sent up by pharmacy to make sure that it is correct. Another popular low molecular weight heparin is Lovenox. Lovenox is sub-Q. You guys probably have given it in the clinical setting. The nice thing about Lovenox is it's got a predictable anticoagulant response. Does not require for us to monitor lab values. Just remember how to give it, and that you don't rub after it after administration, and that the Lovenox, prepared Lovenox syringe comes with an air bubble in it, and that does not need to be expelled. It needs to stay in. Okay, last, warfarin. This is given orally. When we have a patient that's on warfarin, we're monitoring the PT and the INR, but specifically the INR. The INR is the International Normalized Ratio, and when someone is on Coumadin or warfarin, we would like for it to be 2 to 3 for most patients, but if it's a high-risk patient, such as someone who might have a mechanical heart valve, then it can go up to 2.5 to 3.5. It's kind of difficult because warfarin can be difficult to regulate in some patients, and it can take up to 4 to 5 days for them to be therapeutic. And if we happen to give too much, then we give the reversal agent vitamin K. One thing with Coumadin is that we just need to make sure that the patient needs to eat a balanced diet. That with their balanced diet, we want them to not suddenly increase large amounts of green leafy vegetables. That contains vitamin K. Okay, and so if they would get too much vitamin K, then it could actually lower the effects of the warfarin. So the main thing is that if they just eat a normal, balanced diet and don't suddenly increase their consumption of green leafy vegetables. If they currently eat green leafy vegetables, then that's fine, but they wouldn't want to suddenly increase or include a large consumption of green leafy vegetables. So these are the 3 anticoagulants I want you guys to focus on. Listen, you guys need to make sure that you're talking to the patients. You need to make sure that they understand that if they all of a sudden have like nosebleeds or bleeding gums, or that it's taken a long time for a cut to stop bleeding, or that their urine or stools change colors, or they all of a sudden have vaginal bleeding, or they're coughing up blood or vomiting blood, that they need to immediately seek the advice from their healthcare provider. We want to make sure that these guys on all these need or understand that they need to monitor for these potential side effects, that they use a soft bristled toothbrush, that they don't use a straight razor if they're a guy or a lady and shaven. And we as nurses want to be aware of the fact that we really shouldn't be giving these guys intramuscular injections. There could be bleeding into the muscle then. Okay, last but not least, we're going to talk about the drugs for angina. And the good thing is, just really one new class, we're going to talk about the nitrates. But you have to realize that a lot of times, too, when people experience angina, they are placed on a beta blocker or a calcium channel blocker, and we've already talked about these drugs. Okay, for angina, we have the nitrates, and the nitrates relax vascular smooth muscle, leading in vasodilation. When we have vasodilation, we have better oxygenated blood flow to the myocardium. If we can deliver more oxygenated blood to the myocardium, then hopefully we can establish a balance between oxygen supply and demand and decrease the chest pain or angina that your patient is actually having. You guys really need to understand that there's rapid acting forms that patients will actually utilize for an acute anginal attack versus a long acting form which is used to prevent angina, and they are not interchangeable. So rapid acting forms would be your sublingual or your buccal, okay? We can actually give nitrates intravenously, but your long acting would be your PO or your paste, such as your ARBs. So when we put a nitrate or give someone a nitrate, side effects, a lot of times they can have postural hypotension. We have to be very cautious. We need to make sure that patients understand that they need to change position slowly when they take their nitrates. A lot of times, especially when patients first start using nitrates, they develop headaches. And so as they build up of a tolerance to nitrates, the headaches diminish in the intensity and frequency, but they do require treatment, oftentimes with like acetaminophen. A lot of times the hypotension can lead to what we call a reflex tachycardia. It can actually kick up your heart rate. And we want to make sure that we realize that patients can develop an actual tolerance. And so we want to talk to patients about how to hopefully avoid a tolerance. Some nursing implications for patients who are taking nitro. So if it is sublingual, we want to make sure that they understand to not chew or swallow, and that the burning or tingling sensation felt is actually a good thing. It means that the drug is still good. We want to make sure that patients understand that the sublingual nitros come in an amber or dark glass bottle. This is necessary for the drugs to keep their potency. Nitro is absorbed into plastic, so they should be left in the glass bottle, and nitro is sensitive to light. They need to keep track of when the bottle of nitro is open, and that it typically loses its effectiveness after 3 months, and that they need to keep them on hand. We also need to talk to them about the concurrent use of ED drugs, such as Viagra, okay? That can cause a really significant drop in blood pressure, and so patients need to understand that they should not take, like if they're taking Viagra, they should not have nitrates in a 24-hour period. And for some of the longer acting ED drugs, such as Cialis, it could be even up to 48 hours. We need to use gloves when handling nitro patches and paste, and we need to tell patients and their family members that they should do the same thing, that they should also use gloves. One thing that I didn't mention on the previous slide is about the tolerance, okay? So patients who take nitrates on around the clock actually can form a tolerance. And so we want to make sure that we tell them at nighttime to remove their patch like at bedtime for 8 hours, and then to apply a new patch in the morning. And we need to hopefully follow that in the hospital too. And when we are giving patients a nitrate patch or paste, we said use gloves. You want to rotate the sites also. Additionally, if someone is having an acute episode of angina, then our short acting would be to give sublingual. So we tell our patients, stop the activity, sit, lie down, take a sublingual nitro, and if in 5 minutes there's no relief, you call 911, and you can take a second one. If no relief, in 5 minutes you can take a third sublingual. Don't try and drive yourself to the hospital. Now, if we're in the hospital giving these 3 sublingual nitros, in between, we're making sure that we monitor the patient's blood pressure, heart rate, and pain levels. Okay, that concludes this Explain Everything. If you have questions, just let me know. My students know where to find me. If you're just dropping by my YouTube channel and you have questions, be sure to know that you can email me at nurse.polly.rn, and that's at Gmail. That's nurse.polly.rn, and that's at gmail.com. Thanks for stopping by.